Hello, this is the concept bridge on overview of inguinal hernia in children from Dr. Nesmani, ACPG MAT. This concept series is meant for medical students, postgraduate students, both undergraduate and postgraduate students, and also faculty. Especially in this topic is meant for pediatricians, surgeons, and the references taken are mentioned in the last part of this presentation. I thank the references given at the end. The channel address is youtube.com/acpgmed, and the links can also be found in facebook.com/acpgmed. My plan is to talk about the introduction, definition, then what are these hydrocele, hernia, incarceration and strangulation, then some details about the embryology of this hernia, testis and ovaries are also dealt with, and the anatomy of the hernia. Then regarding epidemiology of incidence, incarceration and associated conditions, I will talk about. Then we shall discuss clinical features, if there is no mass, then reducible mass, and then incarcerated mass. Then the differential diagnosis, imaging, laboratory evaluation, then the management, no mass and reducible mass, inguinal mass in a female, incarcerated inguinal hernia, manual reduction, surgical repair, then timing of the repair, the contralateral exploration, then the postoperative care, the complications, summary and recommendations, and the last part will be the references, a list. So that's my plan. So let us start the discussion on the inguinal hernia in children. Primary inguinal hernia occurs in about 1 to 5% of all newborns and 9 to 11% of those born prematurely. So in premature the incidence is a little higher. Inguinal hernia repair is the most commonly performed surgical procedure in children. Most children with inguinal hernia have minimum symptoms. The diagnosis is usually made easily. Repair generally is uncomplicated. Strangulation can be avoided when incarceration is promptly recognized and treated. Definitions. Hydrocele. A hydrocele is a fluid-filled collection that can occur anywhere along the path of descent of the testis or the ovary. Hernia is the protrusion of a portion of an organ or tissue through an abnormal opening in the wall that normally contains it. Incarceration describes a hernia that cannot be reduced by manipulation. An incarcerated hernia may or may not be strangulated. Strangulation refers to vascular compromise of the contents of an incarcerated hernia caused by progressive edema from venous and lymphatic obstruction. Strangulation can occur within 2 hours of incarceration. Prolonged strangulation may rarely lead to necrosis, and in the case of bowel, perforation. Embryology. Testis. The testis appears on the ventromedial aspect of the urogenital ridge on the posterior abdominal wall during the 5th to 6th week of gestation. By 10th week, they have descended through the coelomic cavity. They can be found close to the groin. Processus of genialis forms during the 3rd month of gestation from an outward protrusion of the peritoneum that lines the ventral abdominal wall and forms a diverticulum at the internal ring. Please see the figure. It shows the testicular descent A shows the testis appears on the urogenital ridge, second month. The picture B shows the coelomic cavity evaginates into the scrotal swelling where it forms the processus vaginalis, that is middle of the third month. The C shows the testis begin descend into the scrotum guided by the gubernaculum, that is seventh month. And the D is the process vaginalis obliterates spontaneously, that occurs shortly after birth. The picture shows the caudal genital ligament, testis, phallus and symphysis in the figure A. In figure B, you can see the gubernaculum testis, which is colored red, process vaginalis and the testis and scrotal swelling. In figure C, you can see the testis again, process vaginalis and gubernaculum testis, and furthermore descent of the testis is shown here. And the last part, the figure D, parietal layer of the tunica vaginalis, visceral layer of the tunica vaginalis and gubernaculum testis, and the procession of the testis in the scrotum is shown. Between the 7th and 9th month of gestation, the testis descend through the internal canal and into the scrotum, pushing the process vaginalis ahead and protruding into the cavity. Once this process is complete, the processus vaginalis obliterates spontaneously, usually by the age of 2 years. Ovaries. The descent of the ovaries is similar to that of testis, except that the ovaries do not leave the abdominal cavity. Diverticulum of neck in girls corresponds to the processus vaginalis in girls, and is a pocket of peritoneum that extends from the uterus to the labia majora. It normally closes spontaneously at about 7 months of gestation. The closure of the processus vaginalis may be hindered by the persistence of the smooth muscle. Myofibroblast, thought to represent differentiation of smooth muscle, and failed apoptosis were found by electron microscopy in all inguinal hernia sac specimen of 20 children, 10 boys and 10 girls. The myofibroblast, thought to represent differentiation of smooth muscle and failed apoptosis, were found by electron microscopy in all inguinal hernia sac specimens. It is the persistence of the smooth muscle which is hindering the closure of the processus vaginalis. Anatomy. The inguinal canal is an oblique channel through the abdominal wall through which the spermatic cord passes from the abdomen into the scrotum in boys, and the round ligament passes from the abdomen to the labia majora in girls. It is formed by aponeurosis of the external oblique muscle anteriorly and transverse abdominis muscle and transverse salis fascia posteriorly. Aponeurosis of the external oblique muscle anteriorly, transverse abdominis muscle and transverse fascialis posteriorly forms the inguinal canal. The figure 2a shows the inguinal anatomy illustrated in panels from A to D. The inguinal canal is formed by the aponeurosis of the external oblique muscle anteriorly and the transverse salis fascia and transverse salis abdomen posteriorly, which will be shown in the B and C panels coming. The external inguinal ring is formed by the external oblique muscle, which is shown in here. The internal inguinal ring is located in the transverse salis fascia, composed of the transversus abdominis and internal oblique muscle, which are shown in the figure B and C. The femoral vessels exit the abdomen posterior to the inguinal canal D. So let us see the picture A, which shows the inguinal ligament, lateral femoral cutaneous nerve, external oblique aponeurosis, intercrural fibers, external inguinal ring, and spermatic cord. Panel B shows the internal oblique, transversalis fascia and transversus aponeurosis. And this is to show the posterior part of the inguinal canal anatomy. The transversalis fascia and the transversus abdominis muscle from the posterior wall. The internal inguinal ring is located in the transversalis fascia and composed of the transversus abdominis and internal oblique muscle. The panel C shows the spermatic cord, the fascia iliaca, transversus abdominis, transversalis fascia, then the internal inguinal ring, The internal inguinal ring is located in the transversalis fascia and composed of the transversus abdominis and internal oblique muscle, which is shown well here. The last panel D shows the femoral vessels exit the abdomen posterior to the inguinal canal. It shows the iliopsoas, fascia iliaca, external iliac artery and vein, pectineal fascia and pectineus muscle, femoral vein and femoral artery. So that is the anatomy. So I was showing you the figures to illustrate the inguinal anatomy. Once again, just total repeat. That shows the different walls of the inguinal canal and how the two rings are formed and what are the structures which pass through the canal. Hasselbalch's triangle bounded by the inferior epigastric vessels, the inguinal ligament and the rectus sheath is an area of the posterior wall at particular risk for direct herniation. The external inguinal ring is formed by the external oblique muscle just superior and lateral to the pubic tubercle. So there is a Hasselbalch's triangle bounded by the inferior epigastric vessel, inguinal ligament and the rectus sheath, that is an area of the posterior wall at particular risk for direct herniation. The external inguinal ring is formed by the external oblique muscle just superior and lateral to the pubic tubercle. Internal inguinal ring is located in the transversalis fascia, composed of the transversus abdominis and internal oblique muscle. These anatomies are very important. Now in this figure 2b, spermatic cord course is shown. This transverse section of the anterior abdominal wall demonstrates the structures that form the external and internal inguinal rings. External inguinal ring is formed by the external oblique aponeurosis. Internal inguinal ring is located in the transversalis fascia and composed of transversus abdominis and internal oblique muscles. The broad arrow represents the course of the spermatic cord. In the picture 2b, you can see the external inguinal ring, the rectus muscle, the urachus, the obliterated umbilical artery, the peritoneal cavity, inferior epigastric artery, internal inguinal ring, peritoneum, the transversalis fascia, the transversus abdominis muscle, internal oblique muscle, and external oblique aponeurosis. The muscles from inside or outside are transversus abdominis, internal oblique, and external oblique aponeurosis. In infants, the inguinal canal is short, crosses the abdominal wall perpendicularly rather than obliquely, so that the external ring is situated almost directly over the internal ring. This anatomic alignment places infants in particular risk for development of inguinal hernia, especially premature infants, in whom intra-abdominal pressure may be increased by mechanical ventilation. Various types of inguinal hernias and hydroceles may occur depending on where and to what degree process vaginalis becomes obliterated. This is illustrated in the following examples. A widely patent process vaginalis that permits herniation of the bowel through the internal inguinal ring results in an indirect inguinal hernia, which is shown in the figure. On your right side, that shows the rectus deferens, patent process vaginalis, epididymis, gubernaculum testis, tunica vaginalis, and peritoneal cavity. And this picture shows the patent process vaginalis allows open communication between the peritoneal cavity and scrotum. This transverse section of the anterior abdominal wall illustrates the herniation of the peritoneal content into the inguinal canal through the internal inguinal ring along the course of spermatic cord. And this was the picture which I showed a little bit ago. A narrowly patent process vaginalis that only permits passage of peritoneal fluid results in a communicating hydrocephalus. Here you can see the rectus deferens, epididymis, testis, hydrocele, and patent processes vaginalis. A narrowly patent process vaginalis that only permits passage of peritoneal fluid results in a communicating hydrocele. Hydrocele of the cord occurs when processus vaginalis is obliterated proximally and distally, but remains patent in the mid portion along the spermatic cord. The hernia sac generally contains peritoneal fluid, as in a communicating hydrocele or bowel. In girls, the ovary is commonly involved. Hernias containing fallopian tube and uterus have been reported. Indirect inguinal hernias, the most common type in children, pass lateral to the deep epigastric vessels through the inguinal canal, that is shown in the figure 3AB. Direct inguinal hernias are medial and inferior to the deep epigastric vessels and do not go through the inguinal canal. Indirect inguinal hernias pass through the inguinal canal and they are lateral to the deep epigastric vessel. The direct inguinal hernias are medial to the deep epigastric vessel and they do not pass through the inguinal canal. The picture on your right side shows the external inguinal ring, the rectus abdominis, urachus, obliterated umbilical artery, peritoneal cavity, inferior epigastric artery, internal inguinal ring, and the hernia, which is shown in the form of a thick arrow. Peritoneum is also shown, transversalis fascia, transversus abdominis, internal oblique, and external oblique aponeuros also shown here. Direct inguinal hernias are medial and inferior to the deep epigastric vessels. As seen in this transverse section of the anterior abdominal wall, hernia passes directly through the external inguinal ring and does not traverse the inguinal canal. Direct inguinal hernias are rare in children and usually follow an indirect inguinal hernia repair. Femoral hernias below the inguinal ligament and medial to the femoral artery also are rare in children. In this picture you can see the femoral hernia in this sagittal section. A femoral hernia protrudes through the femoral ring posterior to the inguinal canal. You can see the inguinal canal, lymph node, inguinal ring, femoral hernia which is shown colored, the great saphenous vein, the pectineus muscle, obturator exterior, obturator interior, superior pubic ramus, peritoneal cavity, the peritoneum, transversalis fascia, transversus abdominis, internal oblique muscle, external oblique muscle aponeurosis. So that was the initial part of the presentation. Since this presentation is long, I will be dealing with the remaining part like epidemiology, clinical features and management, the part number 2. So please visit the channel youtube.com/scpgmed. The part 2 is also available in the same channel.